This is HCA's Surgical Safety Checklist. It contains 29 distinct safety steps. Nobody's expected to memorize it all and do it by heart, but by going through the checklist one item at a time, surgery is a lot safer. Recent publications in major medical journals show that use of a checklist like this can prevent errors and reduce the rate of major surgical complications and death. The first was published by Haynes and his colleagues in 2009. They showed that introduction of the WHO surgical checklist was followed by a 36% reduction in major surgical complications and a 47% reduction in perioperative death. In October 2010, Neely and colleagues reported in JAMA on the introduction of medical team training to VA hospitals throughout the United States. Much of the training was focused on surgical safety checklists. They reported an 18% reduction in operative mortality. And in November 2010, De Vries and colleagues reported on the introduction of a comprehensive system of surgical checklists to hospitals in the Netherlands. They reported a 31% reduction in major complications and a 47% reduction in operative mortality. So, what's the best way to make sure that these 29 steps actually get done? One approach would be to have the circulator check some boxes on a form in the chart, or check some boxes on a form in the computer. But checklists are not made to be done in isolation. They work best if the team members interact with each other and cross-check each other's work. In aviation, checklists are performed using a challenge-response model. The co-pilot challenges the pilot by reading a question, and the pilot must check the item and respond. In the clip that follows, notice how the pilot doesn't just respond by rote, but actually physically touches the item to be checked. This is from an Air Force training video.
4-star checklist.
Seat belts.
Fasten.
Fasten. Fasten. Park and brake.
Set.
Circuit breakers.
I'll check mine, you check yours.
Roger.
Set.
Set. Electrical panel.
Set.
Emergency stand.
The challenge-response model is clearly what HCA had in mind. That's why it says right across the top, team members should stop activity and respond to each question of the briefing, timeout, and debriefing. The checklist also clearly shows that it's the circulator's job to initiate each part. The circulator is like the co-pilot in this model and is expected to ask questions of the surgeon and the anesthesiologist to be sure that everything's been done. Now we're ready to look at the briefing. The briefing is a conversation between the circulator and the anesthesiologist. The surgeon doesn't even have to be present. The patient is still awake, and so it's perfectly legitimate to ask the patient some of these questions. The first item is to confirm the patient identity, then to confirm the procedure, the site and side, then to double check about allergies. Item 4 is to confirm the anesthesia safety check has been completed, and item 5 is to inquire about a difficult airway. Here's a training video from the WHO showing the wrong way to do the briefing.
Okay, let's do our sign-in. I've checked all the boxes, so I think we're all set.
And here's a better way to do the briefing.
Good morning, this is Richard Wright. He's here for a left inguinal hernia repair. I've confirmed his consent is in the chart, and Dr. Gawande came earlier and marked his left inguinal region. Has the anesthesia safety check been completed?
Yes, it has. Everything is working fine.
And the pulse oximetry is on the patient?
On the patient.
Excellent. Does this patient have a known allergy?
No.
Does this patient have a difficult airway?
I'm not anticipating one, no.
And do you anticipate a risk of more than half a liter of blood loss?
No, I don't think so. I think we'll be all right.
Okay, excellent. I am in agreement. Let's go.
Step 2, the timeout should be done before the surgeon is handed the scalpel. Ideally, in item 1, the team members will introduce themselves, but some surgeons will refuse to do this, and if so, it's okay for the circulator to announce the names. Item 2 is a double check that the correct procedure and the correct side are chosen. Imaging is double checked and the side is confirmed with the imaging and with radiology reports. Item 3 is where much of the safety happens. This is where we double check to make sure that the antibiotics have been given, that DVT prophylaxis has been considered, normothermia assured, a discussion of anticipated blood loss, making sure that a type and screen or a cross match is in the blood bank, etc. How safe do you think this patient is?
Okay, it looks like we're all set to go. Do we do our team introductions? Dr. Gawande?
Team introductions. All right, I'm the surgeon. It's time to go.
Okay, on the circulator, I'm Tom. Can you,
No. Let's get going. Let's get going.
can you do your timeout,
We're already
please?
behind.
Can you do your timeout, please?
Richard Wright, I guess we're doing a right inguinal hernia repair. This is totally routine. Let's get going. Mike,
Any unexpected steps or critical events?
incision.
Do you want?
Do you want me to get some antibiotics? No.
Okay, everyone, it looks like we're all set. So this is the first case of the day. So can anyone just identify themselves? My name is Tom Weiser. I'm a circulator.
Tool one, the surgeon.
Lauren Scott-Tech.
Alex Hannington, anesthesiologist.
Great. Okay, and Dr. Gawande, can you identify the patient and the site and procedure, please?
So this is Richard Wright. This is for a left inguinal hernia repair. The site marking is showing.
Okay. Any critical events or steps that you anticipate?
No. This is a routine inguinal hernia repair. It should be under an hour and minimal blood loss.
Great. Anesthesia problems?
No problems. Healthy guy.
Great. And Laura, you're all set?
I'm all set.
And you have your mesh?
I do.
Antibiotics have been given?
Grandma Ansett was in 5 minutes ago.
Okay, and Dr. Gawande, do you need any imaging?
No imaging needed.
Okay, I think we're all set. Thank you.
And finally, the debriefing. This starts with the circulator's announcement of the results of the final count, and this is an ideal time to complete the rest of the debriefing as well. It doesn't take any extra time that way. Confirm the exact procedure, the exact diagnosis, confirm that all the specimens are labeled appropriately, discuss any delays and any changes in the equipment that need to happen, and this is also a good time to discuss any special issues regarding patient recovery. Here's what's likely to happen if you wait till the end of the case to do the debriefing.
Anyone want to do the sign out? We did a left inguinal hernia repair, and the sponge counts are correct, so I guess we're all set.
We're closing now, so Tom, this is probably a good time for a sign out.
Okay. Alrighty, so I have the name of the procedure down as a left inguinal hernia with mesh.
That'd be correct.
That's correct. The instrument and sponge counts, the needle and sponge counts are correct. I confirm that. I also have a specimen that's labeled left cord lipoma for Richard Wright.
That would be correct.
Okay. And were there any other problems with equipment or instruments?
No.
Critical events or concerns for post-op recovery and management?
No, nothing on my. Actually, we should hold this aspirin until tomorrow. Priya, can you make sure that gets into the discharge instructions?
So hold that aspirin until tomorrow. Okay. Anything else?
You did fine up here.
All set.
Okay. Thanks, guys.
Many of us started out in medicine with a rather romantic idea that sometimes we might be able to save lives. Surgical safety checklists have been shown in study after study to do precisely that, their use associated with a substantial reduction in surgical mortality. The checklist is an important step on our journey to excellence.